Welcome back to Falcon Physician Reviews. We're now looking at section 22, the thoracic cavity and lungs, as we start to look at the contents of the thoracic cage. In a chest film of a newborn infant, the most obvious structure seen in the anterior mediastinum is the thymus gland. The thymus gland is going to be prominent in the infant because of its position and activity level in early embryogenesis as well as early infancy. Of course, as the adult life carries on, the thymus becomes fairly involuted and gets pulled up through growth into the superior mediastinum. All of the structures, including the aortic arch, is in the superior mediastinum. The right atrium, right ventricle, and the thyroid gland are going to be in different components of the mediastinum as well. So this question is really focusing in on, do you understand the regionalized areas associated with each portion of the mediastinum? When we look at the thoracic cavity in this slide here, you can see that we've got a picture of the heart and lungs in situ, which really breaks down into a couple different cavities. We have a right and left lung field, and we have the mediastinum, which sits between the lung fields. You should be familiar with that. Against the lung field, we have the visceral pleural and pericardium, which have no pain receptors, and the parietal pleural and pericardium do have somatic pain fibers. Therefore, irritation of each of these can cause pinpointable pain, and the others either no pain or very diffuse visceral referred pains. What we can do then to help you along with this is remember that the thoracic wall has the ventral rami associated with them, which are somatic, and the pericardium has the phrenic nerve associated with it, which is somatic. Here you can see the parietal pleura and the fibrous pericardium of the heart that have been identified, and then the visceral pleura would be right against the lung itself, and likewise with the heart, the serous pericardium that we'll look at momentarily is going to be on the inside of the fibrous pericardium, and also the visceral layer is going to be on the heart itself. Here's a normal chest x-ray showing how these structures are viewed in a plain film. You can see the trachea as a lucency, and this one is particularly pointing at a spinous process that's more visible through that tracheal lucency. Here you can see the clavicle with a little bit of distension. Now we can see the bifurcation of the bronchi. So the primary bronchi will be coming off at that carinal level. Looking at the width of the heart, it needs to be less than half of the thoracic cavity size, otherwise you're thinking about cardiac hypertrophy and potentially heart disease. We have the right atrium, the aortic knob, also known as the aortic knuckle. The descending aorta can be seen, but is difficult to trace across because it's overlaid by the other structures of the mediastinum. Here you can see the hilum of the lung with some fluids and tubes from the secondary bronchi. The breast contour is sitting out laterally. The gas in the stomach sitting underneath the diaphragm. And the dome of the liver sitting up on the right side. Notice how the dome of the diaphragm is higher than the left side where there's the fundus of the stomach. This costodiaphragmatic recess is a potential space that will be occupied by fluids since it's the lowest lying area in the thoracic cavity inside the pleural space. So if there's too much pleural fluid or there's an effusion from blood or some other fluid substance, it will run to this area as long as the person is able to stand up. When we look at the mediastinal components, it's a good reminder to get an idea of where all of these things are. You have the angle of Louis and the plane of Ludwig, which will come across at T45 disc. Then above that there's a superior, and below that there's going to be the inferior. Inferior is divided up into the anterior, middle, and posterior. The anterior has the thymus of it in there as a infant, but that too is going to disappear, and really there's very little in the anterior mediastinum. You can consider the internal thoracic vessel part of that, and some involuted fat from the thymus. Of course, you wouldn't be surprised to see thymus in that area in an adult even, but this would be unusual. The middle mediastinum is going to contain the pericardium and the heart. Remember that the phrenic nerve is inside and part of the pericardium, therefore it's considered a portion of the middle mediastinum as well. And then the posterior mediastinum, which is going to have the aorta, esophagus, thoracic duct, several things like that, including the sympathetic chain. As we move into the superior mediastinum, there's a few contents that are lined out here. Anterior mediastinum, same thing. Spend a little time looking at the contents. And the middle mediastinum, which we've already discussed, make sure you remember the phrenic nerves are in that area as well. So a lot of times any hypertrophy of the heart will push the phrenic nerve into a new position. The posterior mediastinum is going to basically be from T5 through to T12 area, and is going to lie behind the pericardium. Clinically, some people will include contents that run through the inferior posterior mediastinum and the superior mediastinum, all to be part of the posterior mediastinum. So be cautious that you're communicating effectively there and that you're reading the question very carefully to ensure that they have the same definitions of the different portions of the mediastinum. The lungs will have surface projections, and it's important to have a good mental understanding of what's happening with the surface projections. One important thing that you should remember is that the oblique fissure will separate the superior and inferior lobes of both lungs. And on the right, where there are 3 lobes, it will also have the separation with the middle lobe being above it. The horizontal fissure will come across at the 4th rib space, and oftentimes if you get someone to raise their arms up and you follow the medial border of the scapula, that will actually come across the same plane as the oblique fissure. The lung itself will end at the levels of the 6th sternal rib, the 6th midclavicular, the 8th rib at the mid-axillary, and the 10th rib at the posterior vertebral border. We'll look at this in a moment in a graph form, but first let's do a question. While listening to a patient's heart with a stethoscope positioned over the 2nd intercostal space immediately adjacent to the sternum, you hear an abnormal heart sound. Where do you suspect a defect? And this is going to be where you would listen for the pulmonary valve. The pulmonary valve, so this is part of auscultation. Along with lungs and heart, we're wanting to think of the auscultation sites. This is going to be high yield material for the board, so please make sure that you spend some time with it, and we'll talk about them in a few moments. When you think about auscultation of the lungs, there's a couple spots that you want to think about. The triangle of auscultation, which is at the approximate level of T7 or to T9, this is the space that has very little muscle mass in the way because it's bordered by the lateral edge of the trapezius. The inferior edge of the latissimus dorsi is going to be there, and the medial border of the scapula. So with very little muscle in the way, you can actually get a very good sound from the superior lobe. When you think about auscultation for the base of the lung, you're thinking about the level of T10, as we discussed earlier, because that's going to be the base of the lung itself along that lobe. For cardiac auscultation, there's 4 areas that you want to be aware of. First is the right 2nd intercostal space, where you'll hear the aortic valve. Second is the left intercostal space, where you'll hear the pulmonary trunk. And then the atrioventricular valves can be heard at the left mid-sternal at T3-4 intercostal space, and the bicuspid being heard at the left fifth intercostal space with the midclavicular line. The reason that you auscultate and listen to the sounds not where the valves are, but where the sound will carry through via Doppler effect, so that you get better separation of the cardiac sounds. I'm sure you'll talk at great length about this in cardiac phys. Let's move into the bronchial tree. As a reminder, we know that the lung has primary, secondary, and tertiary lobes. Those tertiary lobes make up the bronchopulmonary segments, and from embryonic life, these are going to divide 2 to the 17 generations fetally, and then about 10 more generations after birth. And that's going to give you a lot of alveoli for gas exchange. Both lungs have about equal numbers of alveoli, but the left lung is going to be smaller because of the cardiac components, and the right lung will be a little bit smaller because the liver cuts into its space. Of course, with cardiac hypertrophy, the usable space can be greatly changed in one lung from the other because of the hypertrophy. That right lung has 3 lobes, a superior, middle, and an inferior. Superior and middle are above the oblique fissure, and it's broken down into 10 bronchopulmonary segments. The 2 crucial bronchopulmonary segments that you need to be aware of are the inferior posterior basal lobe and the superior basal lobe, both of which are, of course, in the basal component of the lung. So these are important because the inferior one will collect structures if they're inhaled when somebody is ambulatory or upright, and if they're in a bed or laying down, they'll collect it in the superior. The reason for this is because of the branching angle of the primary bronchus, and you can see on the right side the primary bronchus has a much straighter pathway than on the left side where the primary bronchus arches away at a more severe angle. This left lobe of the lung has 2 components to it, the lobes and superior and inferior. It has a lingular portion, which is a fusion of the middle lobe, so it's a remnant of that middle lobe, but it's really an actual part of the superior lobe in the left side. It starts out with 10 bronchopulmonary segments because they both divide the same number of times, but a couple of these lobes will fuse together. Now, this is just a picture of the alveoli of a negative casting to show how much space and surface area there is associated with just one lobe of a human lung. If a child is brought into the ER after inhaling a small object, which lobe of the lung would you begin your search for the object? As we've just discussed, you should be thinking about the right inferior lobe. The child was brought in, they were not spending a long time in the bed or in a supine position at all. So what you want to really be thinking about is that inferior right lobar branch. In this slide, let's discuss the nerve supply of the lungs. The pulmonary plexuses involve sympathetics and parasympathetics and visceral afferents that are running with them. There's a superficial and a deep cardiac plexus, which can sometimes get broken down into cardiac and pulmonary plexus. The sympathetics will provide postganglionic fibers from T1 to T4 thoracic sympathetic ganglia, and the parasympathetics will come from the vagus nerve. The vagus nerve tends to supply preganglionics, whereas the sympathetics tend to supply postganglionics. Remember, the parasympathetics are arresting, so they're going to produce bronchial constriction and mucus secretion, whereas the sympathetics are a system that rev you up, so they're going to relax the bronchial smooth muscle to allow a larger diameter tube of air for any flight or fight responses that are needed. The visceral afferent system is going to be important because it's bringing back sensations from the bronchial mucosa, and that will help it participate in the cough reflex. The fibers from the vagus are where they're going to be carrying that back in reflex control of respiration. The pulmonary arteries are going to be supplied and carrying deoxygenated blood from the right ventricles to the lungs, and they're going to arise from the pulmonary trunk outside that pericardial sac. There's going to be a left pulmonary artery which attaches to the aortic arch by the ligamentum arteriosum, and that's going to be the remnant of the ductus arteriosus. This can be a tether point which can become damaged in high velocity impacts and car accidents, so listen for very quick changes in vascular status and the collapse of a systemic vascular system, because that can be an indication that there may be a tear to the aorta, oftentimes which will occur around that ligamentum arteriosum. And it's at this point that you get the recurrent laryngeal nerve coming around. So any recurrent laryngeal nerve damages that can cause rasping of the voice will oftentimes be associated with that recurrent as it comes around this area as well. The right pulmonary artery is going to cross under the arch of the aorta to reach the hilum of the right lung. As far as pulmonary veins, they're going to be carrying oxygenated blood from the lungs back to the left atria, and they're going to be located in the inferior areas of the hilum of the lungs. One thing that people oftentimes forget to spend a little bit of time on are those bronchial vessels. Remember, bronchial vessels are part of the systemic vascular supply, so they are branches off of the aorta. And the lungs are involved with the pulmonary system in gas exchange, but they also need these tissues that are living tissues to be supplied with oxygen and nutrition, and that's going to be coming through these bronchial vessels. In fact, it's this organization of each bronchopulmonary segment having an independent pulmonary artery, pulmonary vein, and bronchial vein, which allows surgeons to remove one bronchopulmonary segment instead of having to remove a whole lobe or an entire lung like they used to do. The veins from this system are going to be draining deoxygenated blood from the bronchial tree and the visceral pleura. They're going to empty back into the azygous vein on the right and the hemiazygous vein on the left. As far as lymphatic drainage of the body, we have the thoracic wall and the upper limb on the right side, and the right hemi-sected portion of the head, which is going to be draining through the right lymphatic duct, and that will come through the jugulothoracic, subclavian, and bronchomediastinal trunks. The rest of the body is getting drained through the thoracic duct. Notice how I said the thoracic cage on the right. Most of the thoracic contents will dump back into the thoracic duct. Everything below the diaphragm will be collected back to that point known as a cisterna chyli, and that cisterna chyli will be a dumping point for any of the chylomicrons, which are too big to be absorbed by the GI tract, that will then be taken into that cisterna chyli and taken back to the vascular stream via the thoracic duct. Therefore, the thoracic duct in the thorax does not have that straw-like interstitial fluid. It's more of a milky, creamy color to it because of those chylomicrons that oftentimes are in there. So if you get an accumulation of lymphatic fluids in the thorax, it's often called a chylothorax. Let's take a look at the pathways of these drainage. Remember, when you inhale stuff, whether it's the dust in the air or pollutants from walking in the woods, you're going to have all of that taken to the very outside of the lungs where the gas exchange occurs. Then it's going to be picked up by the intrapulmonary vessels along the outside, brought back towards the bronchopulmonary or hilar nodes, where there can be the tracheobronchial nodes, sometimes called carinal nodes. Then they'll move up to the paratracheal nodes, and finally into the bronchomediastinal lymph trunk. The bronchomediastinal lymphatics will then carry it across either to the right thoracic trunk or the thoracic duct on the left. And then it's going to dump back into the systemic venous system. One important thing to remember about that third site, the tracheobronchial or carinal nodes, is that those inferior nodes actually have a communication to both inferior lobes. So an inferior lobar drainage of a cancer has a high likelihood of getting across to the contralateral inferior lobe as well. Let's look at the hilum of each lung. The left lung and right lung, you can see that the positioning of the vessels are going to be slightly different. In the left lung, the artery is superior to the bronchial tree. In the right lung, the artery is anterior to the bronchial tree. Oftentimes these can be short-formed as a memory tool called last rat. The last rat will remind you of the positioning. At the apex of the lung, oftentimes there can be damage to the apex as it projects up over the first rib, and that's going to be the cupula. That cupula can oftentimes be punctured through neck injuries, causing a collapse of the lung and respiratory distress problems. So don't think that just shoulder problems on any of the questions in the USMLE will only be shoulder. They may actually tie you back into the thoracic cage. And these are just a few of the structures that you should refamiliarize yourself with if you don't. The pulmonary ligament is really just a misnomer. It's not a ligament at all. It's really just a double reflection of the pleura that's covering over the hilum as a 3D complex structure. Let's look one more time at the topography of the lungs and the pleura. We talked a little bit about this on the surface projections, but what we're really going to be doing now is setting up as a chart, because we want to look at the levels of termination for the bases of the lung in reference to the ribs, as well as for the attachment points of the diaphragm. Because these two structures, if you understand those, will be the same areas where you'll have the reflection of the visceral and parietal pleura, because the visceral pleura will sit against the base of the lung and the parietal pleura will sit against the attachment points of the diaphragm. So what rib levels are they at? The S, the MC, MA, and MS seen in this chart stand for sternal, midclavicular, midaxillary, and midscapular. So where are the lungs base and the visceral pleura located? They're located at rib level 6, 6, 8, and 10, whereas the parietal pleura and the attachments of the diaphragm are located at rib levels 6, 8, 10, and 12. What you'll see at the midclavicular area and the midaxillary as well as the midscapular, you start to get a gap of 2 rib spaces where the lung is separated from the rib attachment of the diaphragm. And this becomes a potential space, and that's that costomediastinal and costodiaphragmatic spaces that are apparent as a result of areas that can't be occupied by lung tissue. Costomediastinal being in reference to where the heart is, and costodiaphragmatic being in reference to where the lungs versus the diaphragm are. Thinking about development of the lungs, we've talked about the generations of bifurcation. Now let's just take that back a little bit and think about these diverticula that need to form. Off of the early cranial foregut, you have a laryngotracheal diverticulum that's going to bud off in the floor of the pharynx during week 4. This tracheoesophageal septum will then separate into a larynx and trachea, as well as a pharynx and esophagus. This lung bud that's going to come off at week 4 will start to grow and bifurcate, and it will grow into the splanchnic mesoderm, which will give rise to the smooth muscle associated with the areas of the tertiary bronchi. That happens by around week 6. The tracheoesophageal groove may not join properly with the distal esophagus at this point, and you can end up with a tracheoesophageal fistula. And this will be a communication between the trachea and the esophagus, which is often associated with the early esophageal atresia. One of the important things to look at in this particular incident, which is one of the more common incidents, is that there can be a vomitus which will have no bile because it's not getting into the actual stomach or past and into the duodenum. So it will come back up after very small amounts of fluid or food and then be aspirated, and they can get an aspiration pneumonia. This is also going to be preventing a fetus from swallowing the amniotic fluid, so you'll oftentimes see this kind of condition accompanied by a polyhydramnios during pregnancy. Okay, let's look at the periods of fetal lung development that are important for you to pay attention to in reference to the development. There's the pseudoglandular period, which will be weeks 5 through 16. Remember, the primordium is not going to branch off until week 4, so this is getting early on. Notice how the lungs are one of the latest forming structures, since in the internal structure of the uterus there's no need for breathing. Then there's the canalicular period, and this is going to be weeks 16 through 26. This is just getting into the portion where the terminal bronchioles will start to give rise to respiratory bronchioles. Until those respiratory bronchioles are really in place, there's absolutely no chance of respiration, so anything before this is going to be incompatible with life. At the very end of the canalicular period, you're starting to get some respiratory bronchioles and some terminal sacs coming off of that, so that there can be a very small percentage born at this stage that will actually survive. And this is really an indication of maybe where you're born. Do you have the right hospital facility to maintain an infant at this stage? Once you get to the terminal sac period, that's going to be week 26 through birth, and there's going to be a lot more terminal alveoli added at this point. And the pneumocytes, the type 2 pneumocytes, are going to start producing surfactant. Think of surfactant as soap or a lubricant, which is going to prevent those very sticky, wet alveolar sacs from sticking one side to the next side. If you have infants born at this level, they can survive as long as you give them an external or exogenous injection of surfactant. In the alveolar period, that's going to be week 32 of gestation through towards the age of 8 years old, when they'll actually finish all of these terminal sac developments. And this is going to basically be a boundary period between the alveolar period, and when this happens is really different from person to person, is probably inconsequential. So if we're looking at a newborn male infant who's experiencing respiratory distress, he has no fever and has fluid in his lungs. Several hours later, he's breathing normally and his lungs are clear. The likely explanation of this would be that the infant was suffering from wet condition. Here we're looking for wet lung. Since this was a transient ischemic issue, not having a fever or any other respiratory distress syndrome conditions that basically cleared itself up, this is typical of wet lung. And a wet lung is when there's still fluid transition from coming out of the embryonic stage and into the infant stage. It can take a little bit of time, up to 8 to 12 hours perhaps even, to clear the fluids from the lungs and start replacing that with air. In fact, looking at the lungs being wet or air-filled is one pathological way that they'll look whether or not an infant was born still or not. If an infant's born still, they'll have fluid in the lungs. If the infant was born alive and then died or was killed, then they will have air in their lungs. That means they have taken breaths. Let's look at a couple other things that will affect newborns with their lung. First of all, there's going to be some changes from the newborn lung to the adult lung. During those 8 years of life before the lung is really matured, we're going to go from 150 million alveoli towards 300 million alveoli. And the surface area is going to be hugely increased during that time period. Respiratory distress syndrome is a fairly common problem in neonates, and it can be from a deficiency of surfactant of the type 2 alveolar cells, or it can be a problem with the surface tension and the inflation. If pulmonary surfactant is rich, there's going to be a level of desaturated phosphatidylcholine or lectin, and that lectin synthesis in the lung is going to increase very dramatically as a lung matures and begins producing surfactant. Surfactant levels are generally expressed as a ratio against sphingomyelin, and sphingomyelin is a non-pulmonary fat whose concentration is pretty constant in the amniotic fluid. So as this ratio starts to change during growth, it starts to be a better indicator of whether or not the maturing lungs are coming into play. Anything greater than a 2-to-1 ratio means that the lungs are mature enough to be survivable. Less than a 2-to-1 means there's a risk of developing respiratory stress in an infant that's born, and there's going to want to take appropriate measures to make sure that there's surfactant on hand. The phosphatidylglycerol, PG, is another lipid that is only found in the amniotic fluid right before birth. So if you find that the phosphatidylglycerol levels are high, it's actually a pretty good indication that they're going to have birth pretty soon. Dexamethasone can be given to help mature the lungs faster, as well as the surfactant. So if there's a pregnancy that's high risk and they want to try to develop the lungs prior to inducement, they can provide dexamethasone for a little while to make sure that that baby comes out with healthy and functioning lungs. Here you can see a couple examples of some of the pulmonary changes that will occur. So you're going to move from amniotic fluid that's going to be replaced by air, which is going to change the resistance in the lungs. Pushing against fluid is much harder than pushing against air, and this is going to change the pressures in the cardiac system as well. The cardiac shunts are going to start to close, and then the pulmonary vessels will start to fill with blood because the amniotic oxygenation pathway is going to be closed down. As far as neural control, the breathing is going to be taken over by the brainstem, and then it's going to have sympathetic activation. And we just got a couple slides here. I think you'll probably spend more time on this in pathology, but you can see how a fetal lung has a lot of fluid and wet tissue to it, whereas that expanded alveolar system of a newborn is going to have a little bit less fluid-like look to it, an expansion of those alveoli, and then at the adult stage there's going to be much more of that expansion. So what can we see in this film? You can see that there seems to be an air density on the left side of this patient. This is a potential for a mediastinal shift to be occurring here. That shift means that the mediastinal structures are going to be pushed over on the inflated lung away from the uninflated lung, and that's going to cause pressure against the only structure that's allowing them to breathe at this point. As you can understand, this is going to have deleterious effects for their survival if it's not dealt with. This is known as a tension pneumothorax, and the tension comes from that air cavity which is bringing in air but not allowed to release the air, which is pushing all of the other structures to the uninjured side. This is going to be accompanied by increased breathing difficulty, shortness of breath, or dyspnea and tachypnea. Weak pulses with tachycardia are going to be an important sign as well, because the heart is going to be compressed with this tension, and there's going to be a drop in systemic efficiency. This is going to cause a drop in systemic insufficiency because the venous system will be compressed. That's always going to be the first system to be compressed by pressure. And that venous system pressure buildup is going to show as a jugular distension and probably a cyanotic appearance of first the lips and then potentially more of the body as this progresses. This is a life-threatening situation. Here you can see that mediastinal shift and that absent lung marking. That's probably the collapsed lung against the heart shadow on the left side. Now, let's look at what happens when you get too much fluids or fluid at all into the pleural cavity. The pleural cavity is meant to have very small amounts of fluid that keep negative pressures against the visceral layer of the lung and the parietal layer of the thoracic cage, such that when muscles are used to inhale, it will fill the lung by stretching it against this negative pressure, and then on exhalation the elastic potential will be reharvested for a passive release of that air. So breathing in takes some energy, but breathing out takes very little energy. If you get too much fluid in that area, whether it's blood or water or some kind of air, you're going to get either a pneumothorax, hydrothorax, or hemothorax. If it gets too fused together, you can have a pleurisy, which can be quite painful because of that somatic nerve plexus that's going to innervate the parietal pleura, and that will be sharp and localized. To drain the fluid, you're going to do a thoracocentesis, and you're going to want to go above the rib level of probably rib 9, which would be at that costomediastinal recess, and then you can do a withdrawal of fluids at this level without risk of hitting either the abdominal structures or the base of the lung itself. So this thoracocentesis is going to be an invasive removal of fluid, air, or whatever's gotten into the pleural cavity. As I mentioned earlier, it could be chyle to cause a chylothorax as well. You have to go through the endothoracic fascia, and that's going to put you into the pleural cavity. If you're not careful, because you're in the mid-axillary line, there is a small chance that you could cause a long thoracic nerve injury, and then would result in a winging of the scapula. Here you can see an issue related to a blood level that's localized into the thorax, and it's masking all of the borders of the heart, which you would typically see. This particular hemothorax was a result of multiple rib fractures, and you can see the fluid levels. Now, in a major chest injury, there's going to be severe pain. There may be paradoxical respiration and other complications depending on the situation, but you're going to have to do pain control and drainage of this. You may have to do a tracheostomy in order to suck out the bronchial fluids and secretions. These are all going to be issues that could play into a testing item as far as the USMLE. As far as draining the tubes or the chest with tubes, you may have something less than 350 milliliters, which typically will resorb on its own. If the lung has not collapsed, then you can simply wait for that to happen. If there's somewhere between 350 and 1500 milliliters, then you're going to have to do a thoracocentesis and probably a tube drainage. And then finally, if there's more than 1500 mils of fluid in there, you may want to keep 2 drains, and then you're going to have to find the source of that immediately. The free end of the tube is going to have to be attached underwater to seal it, and then there's going to be a negative gravity feed, basically like siphoning gas out of your car. If somebody has a pleural effusion, it commonly results in sharp localized pain on the chest wall. Where are the cell bodies of the nerve fibers that carry this pain to the CNS? And this is a reminder of the kinds of questions that will bring back the idea of that basic nerve anatomy that we discussed a couple sections earlier. So where is all of the somatic pain cell bodies located? Remember, we discussed that they are located in the dorsal root ganglia for the chest. And that dorsal root ganglia is going to be located at the level of the intervertebral foramina of the thoracic vertebrae. Remember, it's going to be numbered for the vertebrae that is above it. If it were the sympathetic chain, that's a motor ganglia. If it were the dorsal horn, that would be the secondaries, and it would be a nucleus, not a ganglia, because remember, a ganglia is peripheral by definition. If it were a lateral horn or a ventral horn, again, those would be central nervous system issues and not peripheral nervous system issues, and we're talking about the location of a peripheral nerve cell body. If we move on to the pneumothorax and pleurisy or pleuritis, we can have an open pneumothorax where the pleura may be punctured and the lung accidentally deflate it. And that can happen during surgery, even surgery of the abdomen where you think there may be no contact, but because it's so close to that attachment of the diaphragm, you could get into the thoracic cavity fairly easily. Could be through a nerve block, intravenous line insertion, or a central line, which could damage the cupula near the apex of the lung. Pleuritis is going to be an inflammation of the pleura, and it usually is only involving the visceral pleura, so it may not be painful. But as soon as it starts to get to the parietal pleura, there's going to be pain associated with that. If there's pleural adhesion, this can also cause a lot of difference in rubbing between the visceral and parietal pleura, and those tend to cause pinpointable pain. You may get pain in the shoulder because of thoracic problems, because you can irritate the diaphragm from the superior surface, and this can come through from the phrenic and give you problems with referred pain to the shoulder in the C3, 4, or 5 regions. That pleural pain is often related to a pneumonia of the basal segments or cancer of the lower lobe, which is going to irritate that diaphragm. Or it can even irritate the esophagus and give you a similar feeling as far as abdominal pain. Let's just discuss a few other lung-related conditions. I'm sure you'll talk about these as well in pathology a little bit more, but I want you to think about what's happening with the anatomy and what it's doing to the external structures. As far as emphysema, remember we had that large surface area in the lungs, and the surface area is going to start to be destroyed because you're going to lose the surface area of the elastic tissues that are being impaired. And that's going to go from small little balloons to a large balloon with less surface area and less efficiency. Asthma, an incredibly common obstruction of the airway caused by spasmic contractions of smooth muscles in the bronchial tree, or it can be from mucosal edema or plugging of it. That dyspnea, wheezing, and coughing are going to be characteristic, and precipitating factors would include things like allergens, respiratory tract infections, even emotional issues can affect somebody's breathing rate. Exercise, of course, and some drugs will also play a role. So in the stem of questions that are dealing with asthma, you can see a great range of things, and I think asthma has to be ruled out as a simple possibility depending on the presentation of the method of injury. But for unknown causes, somebody coming in should know they have asthma, but you won't always see that in the cases. Atelectasis is a collapse of the lung tissue from obstruction of the airflow. So this can happen from tumors, mucus, or aspirations, and it's basically a complication of post-operative things as well. And the patient can't cough up or can't get rid of a thick mucus from the bronchial lumen, so it will oftentimes cause a collapse. Bronchiectasis is going to be the similar kind of condition, which is involving chronic dilation of portions of the bronchial tree, which can be caused by prolonged atelectasis, and it can lead to respiratory infection. Emboli, or pulmonary emboli, is going to be associated with DVTs, oftentimes from the lower extremities or the marrow of fat. It can be a post-surgical issue. It can get lodged in the heart or in the pulmonary arteries, and it can cause very instantaneous death if it gets to the bifurcation of the pulmonary trunk, which would be known as a saddle embolism or thrombus. This is just looking at some normal airways versus bronchial spasm and chronic bronchitis airways, where you'll start to get a permanent thickening of that bronchial mucosa. Now, these are just a couple of the things that you can look at as far as bronchitis or emphysema to show the differences graphically in what will happen as you start moving into less